Pass the microphone on to Mark Neumann, who leads Nephrology News and Issues. Thanks again, Mark, for helping to co-host the conference with us and for your review now on the current issues affecting policy for U.S. dialysis.
Thanks, Bruce, and it's a great segue based on what we just heard regarding use of PD. We've got some interesting news that's just taken place over the last couple of days. I'm also going to share some of the data from our annual provider survey that shows PD use is very healthy, and along with a lot of other topics. So let's go ahead and move ahead. We certainly want to talk about the hurricanes. That's been a big story for us, for everybody, really, in the last month. We're certainly now looking at what's going on with Jose, which just hit Puerto Rico this morning. Fresenius, for example, has 30 clinics over there. And there was an effort before that hit to move those patients elsewhere. But it's been really an interesting listening to folks who are in the trenches in these situations, both in Florida and in Houston, about what has been done to help these patients. So there's some really great stories and a lot of effort by everybody to make sure that these patients are safe. So lots of good news there. But let's move ahead and talk about some important things. As I mentioned, we'll talk about PD utilization. This second story just popped onto our screen in the last 24 hours, and I think it's very important. This is some new proposed rules by the Medicare Administrative Contractors. The MACs are the groups that are hired by CMS, in essence, to pay the bills. So facilities don't get paid directly by Medicare. They get paid by these contractors who review the claims and then, in essence, sign a check. Well, there's 4 of these MACs who have gotten together, and they control or they cover roughly about 31 states in the United States in terms of policy, and that's about 60% of the ESRD population. So this decision and this proposed rules, if you will have a major impact. And it's focused on the use of more frequent dialysis. So it's great that we're talking about home dialysis here. A number of physicians, as well as groups like NextStage, are concerned about these proposed rules because it would require, in essence, much more paperwork and justification for these MACs to pay for more than 3 times a week, which we obviously know many nocturnal patients do more than 3 times a week. You have patients do short daily. All that could be potentially compromised by this proposed rule. We just posted a story on this today. In that story are links to each of these proposals because there's 4 total. If you're in those jurisdictions, certainly pay attention to what's being said, offer some comments because most people feel this is going to be detrimental to the renal community, particularly for the home population. So please pay attention to that. We're also going to cover the California unions and the staff-patient ratios. Fresenius, as many of you have heard, has made an offer for NextStage. I'll cover that briefly. Changes to the payment bundle and the QIP. Of course, this always happens at the end of our year when they propose new rules for the following year, so we'll cover that briefly, some minor changes there. Macra, which is the new physician payment program, and how that works and what the status of that is. AKI patients treated in outpatient dialysis clinics, that has been taking place since January and has had a major impact on dialysis operations. Many of our providers talk about how much of an influx of new patients they've been getting based on this rule. So there's some discussion about how these patients are being treated, how they're going to be monitored in terms of quality measures. That's been very controversial. And then lastly, of course, we'll talk about Harvey and Irma and Maria and Jose towards the end of our discussion. Next slide, please. So I wanted to bring this up, but this is data from our July issue. So it's several months old now, but it seemed like a great time to bring this up in terms of what we're covering today with PDOPPS. And what we do every July, really around May, we start gathering this data. We survey the 10 largest dialysis providers in the U.S., and we ask them several questions. Number of clinics, the number of patients they have, which is how they get ranked, and then we divide up those patients into different categories, PD, home hemo, in-center, and nocturnal in-center. And we also look at international clinics. DaVita and Fresenius and Baxter all have clinics overseas, so we gather that data. This has been our 23rd annual survey, so we have lots of data on this. All these surveys, by the way, are posted on our website. So if you want to go back the last 5-6 years and look at trends, that data is available. I might also note that this is a voluntary survey, so we do not have means of cross-checking the data. Every provider gives us the information. We've been very fortunate in that regard, and we have to, of course, assume it's accurate. But everybody seems to have a lot of respect for it, and so far I think we've gotten some really good stories out of it. So here's a synopsis of what we've seen this year in 2017, which reflects changes in patient census over the last 12 months. So it's a point in time. In other words, we asked these providers, what is your patient count as of May 2017? And of course, this accounts for patients' mortality, patients who have passed on, of course, and patients who have gone to transplant. So it reflects all those changes over the last 12 months. So here's our numbers. 20,238 new dialysis patients came on board in the last 12 months. So that's the incident population, again, among these 10 largest providers. As you might guess, the majority are in-center, 18,981. We lost about 900 patients in-center nocturnal, and some of that was just a reflection of the way nocturnal in-center is defined by CMS. So it's not so much that we lost the patients. Some of those ended up being part of conventional in-center. So keep that in mind. Perhaps the most disappointing number is that 72. 72 patients increased over the last 12 months who went on home hemodialysis. This is the kind of thing, as I just previously mentioned, that the MACs are in essence going after. This number could go even further down if there are more restrictions placed on the idea of nocturnal dialysis and short daily hemo. That's the kind of thing that could threaten this very fragile, small group of which is about 2% of our total patient population. And then we have the PD numbers, which are very healthy. This number, 2,090, is close to what we saw in 2015 and 16, and this number has rebounded quite a bit over the previous time. Next slide, please. So as part of this, we also gather information about what providers, in essence, do the best in terms of home dialysis. And so these are what I call rock stars, and then you have what I call the warm-up band. So the two providers who have done very well over a number of years has been Satellite and Northwest Kidney. You can see what the percentages are in terms of their home dialysis population, and this includes PD and home hemo. But you also notice that they have not changed much. So Northwest Kidney actually went down 2%. And then we have our warm-up groups, Dialysis BCI, DaVita, who are doing pretty well at 12%. Fresenius just lost about 2% this past year. But we still have 4 of the 9 clinics providers that we follow in terms of home dialysis who have less than 10% of their patients at home. And I think that's something that really needs to be looked at. Next slide, please. Home dialysis patient growth, figure 2. This shows, again, the growth in both PD and home hemo. As you can see, from 2003 to this past year, we have seen a pretty healthy growth in peritoneal dialysis patients. You can also see where home hemo has gone. There have been some healthy increases from 2014, 15, 16, and then this sudden drop this past year. So that's something that we have to, I think, take a look at. But PD, despite the problems we had with the dialysis shortage a couple of years ago, which dropped PD growth quite a bit, has recovered, and we're seeing it increase. Next slide. This also shows you, again, the percentage of home patients based on the providers. So if you look at it, we started off with our baseline of 2011, and you can see that there has been an increase in the percentage of home patients among these providers. Not a real strong growth, 3%, 2% over the last 7 years. That's probably not considered great, but nonetheless, I think these providers are heading in the right direction, and we hope that they can do even more of that. Next slide. What might help? Well, we also tracked this year the number of providers that are in the new ACO demonstration. This has been going on for a couple of years. All these providers represent roughly about 30,000 patients who are in this demonstration project. There's lots of information on our website about the ESCOs and how this project is moving along, but there's a lot of belief that home dialysis can be a conduit and can be a strong factor in going when providers are looking at the integrated care model. Because what we believe is home dialysis saves on the back end in terms of money and also improves quality of life. And that back end is hospitalizations, less drugs, and if you look at the big picture, those are things that you want to save money on. So that's the advantage of home dialysis in this particular model. So we're going to keep track of this and see if this patient population increases. But there are about 30,000 patients in this demonstration, and that should generate some very good data. Next slide. Okay, so let's talk a little bit about, we mentioned this, I had this in here, we talked about this a little bit earlier. I just wanted to show you on that map that you see there, it's very small, but it does sort of define where these areas are. Again, look to our website today. I'll skip over this, but look to our website today. We posted a story, and there's lots of information about this, but this is a very, very important issue. If we are advocates for more dialysis beyond the 3 times a week, these policies could have a major impact on that. Next slide. Okay, so the news this past month, in fact, it occurred on September 11th, is that the legislator who had been supporting an effort to bring staff-patient ratios to California had agreed to table the legislation. This story has been going on for a number of months now. There was a push to bring staff-patient ratios to California dialysis facilities specifically, and that included nursing, patient care techs, dietitians, and social workers. So this had already made quite a bit of progress. It was a Senate bill. It had gone through the Senate, through the Assembly, and was pretty close to going for a full vote, and then perhaps to the governor's desk. The legislator who supported it, Ricardo Lara, decided on September 11th to table the measure. He is willing to sit down with the different groups and help make a decision that there may be a better way of going about doing this. But there's some other news behind this as well. In between this, he has led an effort to have this create a ballot question for this in November. The intent being that if this doesn't go through, there's an opportunity for the public to make a decision on this. So we're going to keep following this story. There was some guff about this because the unions were back in this effort. There's a sense that they simply wanted to increase membership. The provider community was definitely against this. They did not like a required ratio because of staffing issues and the cost. So definitely points of view on both sides of the fence, and we'll see where this goes. Next slide. So one of the things that we wanted to ask you is what you think of these ratios. There are a number of states that have these, roughly, I believe it's about 8 states that do have ratios at different levels. We want to get your impression about whether you think this would have some value, and do you think states should be making these decisions. So we appreciate your vote. Okay, an interesting response. So we had close to 60% who believe states should adopt staff-patient staffing ratios. And I think this is also an important response in terms of who should be deciding this. Should there be federal guidelines? But clearly, I think people here are saying states should make these decisions. And I think that's an important response. Okay, next slide, please. Some of you, or many of you probably have heard about this story. Fresenius has put in an offer to buy Next Stage Medical. Next Stage, as you know, has probably the best-known home hemodialysis machine on the market. And in fact, if we look at the 2% of patients that are on home hemo in this country, more than likely most of them are there because of what the Next Stage efforts have made. The company was formed in 1988 by Jeff Burbank. They launched the System 1 back in 2003. And got clearance for different versions of home hemo, though most recently the home hemodialysis in June 2005. More than recently, they also got a nocturnal for that approved. And then about a month ago, the FDA cleared Next Stage to allow the machine to be given or to be assigned to patients who don't have a partner. That had been one of the requirements previously. That's now been lifted. So they've made some great progress in that area. Fresenius announced on August 7th that they wanted to acquire the company and was going to be paying $2 billion for that. So lots of interesting things about this, different points of view. Fresenius, by the way, is not only buying the machine and that technology, but NxStage has also been working on a brand new PD machine. And so Fresenius is buying that technology as well. As we know, Fresenius has a pretty strong presence in the PD market. Baxter is there as well. So they're getting more than just a very good compact, portable HHD machine. They're getting other technology. You can look at this as a negative, of course. When big providers buy small companies, sometimes you lose that customer connection. Patients who have been on home hemo for some time like the idea of having a small company like NxStage. So there can be pros and cons to this. We're still waiting to hear about the settlement on this deal, but we expect it sometime, probably sometime in the spring of next year. Next slide. Update on payment and quality improvement. We, as I mentioned earlier, every year, of course, we have the bundle payment that gets reviewed. There are not a lot of changes for 2018. CMS goes through this and looks at changes. There's a little bit of an increase in the payment that they're providing. And so that hasn't changed much in terms of what's in the bundle. There's been a couple of other additions to the QIP, the Quality Incentive Program, where they've added some things to it. We mentioned in here about the administrative contractors, again, how they're reluctant to pay for more than 3 times a week. The negative about the bundle in any situation is, of course, is that the payer can continue to add things into the bundle and not necessarily pay for them. So the bundle as a product and as a payment model has some negatives, but the industry has been doing this obviously since January 2011, and they've gotten used to it. So no major changes for next year. Next slide, please. This just shows you, by the way, a little bit of history about the bundle. I'll go through this quickly. But you can see at the bottom the red bar or the red slice, and that represents ESAs, the drugs. And no question, CMS will acknowledge that one of the reasons why they brought the bundle on board was to control drug expenditures, particularly EPO. And you can see on that graph how EPO use had went up. And then you can also see as it's starting to decline, because the last year there's 2010, which is the year right before the bundle took place. So my sense is that providers were starting to realize that they needed to do something about it. Next slide. And it just kind of gives you a little bit of a review on, again, going back, this is old data, but it's kind of interesting, what happened after that bundle took place. And we have a cover story coming out this month that also looks back historically about how dialysis providers changed their approach after the bundle took place. But these numbers are kind of interesting. It basically focuses on one thing. As soon as the use of EPO became a cost part of the bundle versus a profit part, there was a big change in how EPO was administered. We saw hemoglobins come down a little bit. We saw EPO doses come down. This has all been tracked by DOPPS, of course, but it's clearly providers decided to react to this. And so far, from what we've seen, the hemoglobins, hematocrits have stabilized. Next slide. Okay, Macra. This is a QIP for physicians, in essence, and it covers everybody. Nephrologists, of course, are part of this. Although nephrologists also have what we call the MCP, which is the monthly capitated payment. The bigger picture for nephrology and for physicians in general is called Macra. It has a new name. It's now called the Quality Payment Program. But it's centered on the idea that the physicians, just like providers, should be paid based on the quality of care they deliver. So there's a number of changes that are still taking place. This is still a living document, if you will, but it's centered on the idea that physicians will start to see, if they want to see a pay increase, in essence, they have to show that they're providing good care. Next slide, please. New AKI rule. This took place in January. Many of you have probably seen some effect in your dialysis clinics. This allows physicians and hospitals to direct patients with acute kidney injury to a chronic outpatient dialysis clinic. This was not previously allowed. The number of patients, I mean, this can be a win and this can be a lose for depending on who the parties are. Medicare sees the value here because it will pay less, in essence, for these patients to get care provided, because they're taking them from the hospital, the high-cost hospital environment, and they're putting them in the outpatient environment. So a lot of these patients are being transferred to chronic care units, and this is the definition that they have. It's acute loss of renal function. So these are not ESRD patients. These are patients that hopefully will recover that function. And one thing nice about it for providers is that CMS is relaxing the rules on the 3 times a week dialysis. So if these patients need 5 times a week care, CMS will pay for it, and they'll pay for things outside the bundle. So we're going to see how the outcomes are if these patients actually do better in this environment. As I mentioned, one of the things you can see at the bottom there, potentially, we don't have, our outpatient clinics don't have a lot of expertise in dealing with these patients who are sicker in a different way than the typical chronic ESRD patient. So we're going to see how that comes about. There's lots of studies going on about the outcomes and the results, and so we're going to keep an eye on that. Next slide. Well, I want to just wrap up, if I could, with the dialysis community's response to the hurricanes. Some of you may have been intimately involved in what happened in Texas and Florida. There's lots of efforts on many fronts to help these patients. At one point in Houston, for example, there were close to 60 clinics that were closed. I mean, think about the number of patients that could be potentially involved with that and who had to be moved, and providers had to mobilize and find places to put them. There were patients who couldn't get out of their homes because they were flooded in and couldn't get to their clinics. There were staff members who couldn't get to the clinics. A lot of the clinics didn't necessarily lose power. Weren't flooded, but they lost power. So the objective was to get these clinics back up running as soon as possible. There was very good communication from the Texas ESRD network, and we've seen some good data also from Florida. Most of the Florida clinics are back up. There's about a handful that are still closed. And Texas, of course, is still working on digging out, but many of those clinics are open as well. So now we have to be concerned about Jose, who just hit Puerto Rico, as I mentioned, and we're going to see where it goes. But it's remarkable that we've seen this many hurricanes in 1 year, and that's what most of the weather folks are saying. Category 4 hurricanes come back to back is very unusual. And then, of course, we have other natural disasters, the earthquake in Mexico. So there's lots of things going on weather-wise. I think the renal community has done a great job in responding and preparing these patients. And right now we're still in recovery. So we have a couple stories coming out in the next issue, and we posted several on the website. There's just a little factoid there about 50 inches of rain in 3 days. Imagine that occurring that quickly. It's amazing. Anyway, I'll wrap it up with our resources. It's great to be able to come to this WebEx and present and let everybody know about nephrology news. There's some contact information for myself and for Rebecca, who handles the website. We put out an e-news twice a week. It's free. It's a great way to keep in touch with what's going on. We also do a monthly e-news called Perspectives, where we try to look at issues and do some analysis. And, of course, the magazine is available to you, both digitally and in print. So with that, I'll stop and open any questions.
Mark, I think in the interest of time, we'll wrap things up. But
Sure.
Thank you again, Mark, for your contributions and all that your group does for the community to keep folks informed. There is so much going on almost on a daily basis. It's really quite incredible. So thank you. And thank you to everybody who participated today for your participation. And just a note as well, we will update the U.S. DOPPS Preactice Monitor once again in 4 months with a web conference in January of 2018 with data through October 2017. And of course, we look forward to seeing many of you at the ASN coming up in early November. And with that, thank you very much. And just a note as well, we will have the slides as well as audio from this presentation available within a few days through the DOPPS website. Thank you very much, and have a good afternoon.